What's up, guys? Quinn Henoch here. We've got another Clinical Athlete Rehab case for you at Clinical Athlete Newport. This is a 30-year-old female who's training for the police academy that starts in 6 weeks. She's coming in with a complaint of right plantar fasciitis, which she's had for an entire year, so 12 months with that issue. No prior history of that issue on either side. So before a year ago, that was not a thing. The mechanism, she claimed, was recreational soccer. So she was strength training, she was running, all was well, and then her prior athletic history, she played soccer. She played a lot of it. She played in college. And so she started to play in a rec league once a week, but really intense games, and she said that's when it started. The pain location is the right plantar fascia towards the medial heel, and the trigger activities were soccer, which she's not playing anymore, jogging, sprinting, jumping, and landing. So things that she needs to do to train for the police academy. The timeline is such that the patient's been to physical therapy, and the treatments have been things like orthotics, stretching, massage, ice, so some passive modalities, no imaging, relevant medical history, a left ACL reconstruction 5 years ago, so on the opposite side, and it was a non-contact injury. And she says that her hips fatigue when she runs any more than a mile, so they just become tight. She perceives them as feeling tight just around the joint, and they almost lock up on her. Right now, her normal programming is training 5 days a week for the police academy. Up until 3 months ago, the training consisted of a small amount of running, but mostly strength training. Since that 3-month period, it's shifted to things like calisthenics, lighter weights, running, much more running to accommodate the activities and the demands of the 6-month police academy. The running program consists of 3 days per week of sprints, anywhere from 10 meters to 400 meters, and an additional 2 to 3 miles per week of jogging. So when you add all that mileage up, it's not a ton, but she's having symptoms with all of it. She reports that she is not a heel striker. I saw a video of her running. It was more of a short sprint. I noticed that she would reach, so as in the acceleration phase, she would reach with the heel, almost overreach, and it would end up in a braking mechanism. So what we want to do is put that contact point more underneath the body, and especially in the acceleration phase of a sprint. But she claims that she was not a heel striker. And her goals are to improve her running mechanics, to improve her pacing, and without increases in pain. And obviously, ideally, in the long run, to have a reduction and an elimination of the right heel pain. So objectively, in long sitting, I looked at her ankle dorsiflexion with the knee extended, and she had 10 plus degrees on both sides. With the knees bent, she had 12 plus degrees on both sides of ankle dorsiflexion. So if you're just looking at it from an ankle range of motion perspective, as in, well, maybe the ankles don't move and it's not creating as good of a shock absorption when she lands, that doesn't seem to be the case, at least passively. Now, is she able to access that range? That's a different story. But there was no pain elicited when I was stretching her ankle into maximum dorsiflexion. And the same with the great toe. So both big toes, plenty of passive range of motion. There was no seeming restriction right there. I couldn't recreate the issue by stretching the ankle into dorsiflexion and great toe extension. It wasn't creating her symptoms. We did a standing single leg calf raise test to just gauge her tolerance to multiple reps there and for direct loading. On the right, she completed 20 reps and reported more fatigue on the right with a little bit of pain. And on the left, 20 reps were completed, and she said she could have gone on for days with that. We did a tempo of 3 up, 3 down. So we'll probably put something like that in the program, like a deficit single leg calf raise, almost like a heavy slow resistance for the calf. Supine hip range of motion, passively, flexion, all within normal limits. External and internal rotation. External rotation, she had 80 plus degrees on both sides. Internal rotation, less than 15 degrees on both sides. Now you may ask, why am I even checking hip range of motion for plantar fasciitis? And that's a valid question. For me, she's going to be doing strength training and these types of things, just kind of giving me an idea of what I'm working with, and almost as a point of disprove or reduction, as in, if the narrative is she has tight hips and that's what's causing her pain during running, or that's what's leaking down the chain, is her hips lack mobility, and so she's not able to absorb load the way that she should. I'm showing her, well, your hips in flexion actually have plenty. External rotation, a surplus of what would be considered normal. Internal rotation, that's probably just her normal. It wasn't any different on either side. So the passive hip range of motion testing didn't tell me a whole lot there. It was just something that kind of quick and dirty because of her complaints of hip tightness and pain when running. She was tender to palpation right at the plantar fascia, right at the point of that medial heel, so that's obvious, but we can gauge that, in a month's time when she comes back. If I'm poking on that area and she says, oh, it's not tender like it used to be, that's a plus. It's not as sensitized. She reported that she had flat feet, so she told me, I know I have flat feet, but when I got her shoes off and I had her in standing, I saw that her longitudinal arch flattens a little bit with standing, but that's the normal mechanism. We're supposed to shock absorb and load absorb. That's the point of the arch. She still possessed an observable longitudinal arch in standing. I could still see it. And then when she was in non-weight bearing, just sitting on the table, she definitely had one. So I kind of squashed that narrative there and said, well, you don't actually have flat feet. You have an arch, and you're not supposed to have, these crazy arches that shoes jam us in and then our feet form into that position. That's not necessarily what we would consider normal anyway. So I actually thought her foot looked pretty normal, and thought that her arch was unlikely a contributing factor because she's had this discomfort for a year and she's had her structure of her foot long before that, for the 29 years leading up to the point that she experienced pain. So I don't think that that's a significant contributing factor. The diagnosis here, plantar fasciitis is fine. It's just a load management issue. So if we want to diagnose it as foot pain or plantar fascia pain, if we call it itis, just because that's an ICD-10 code, but your foot hurts and we're going to manage the triggers and modify the behaviors that create the pain and then hopefully build you back up. I think she was likely basing her fitness level a year ago based on her past fitness level, and that's why she thought that 1 day a week of soccer on top of what she was already doing would be no big deal, but she hadn't been doing those things. She wasn't prepared for that anymore. So you can't necessarily base who you are now, what you're prepared for now, off what you had been prepared for. So the running, the hard cutting, all the change of direction stuff, she just wasn't quite prepared for that. And I think that's what her issue was. The unilateral symptoms, why right side and not left? And these are always the great mysteries of life. Obviously, there's some type of force distribution difference from side to side. Maybe it had something to do with her left ACL reconstruction, where she was always kind of got into the habit of favoring the right side, and maybe she was just planting harder on that right side and overloading that right side. I don't know. I'm going to recommend, though, that she increase the load in her unilateral movements in her training, because she had decreased the load on everything, but she's still doing things like lunges and single leg deadlifts and these types of things. Some of her single leg jumps, but for the split squats and the deadlifts and the lunges, I'm going to recommend she just up the intensity a little bit to try to, and do it on both sides, just to try to get some feel of force production symmetry on both sides. And that certainly won't hurt her running. As far as education, I'm fine with her keeping the orthotics in for now. She says it decreases her symptoms a little bit, but I made sure to discuss with her that they're likely not a cure. And in fact, the evidence that I'm familiar with says that custom orthotics are no better than the generic orthotics that you would get at the store. So you can get still some force distribution change and pain reduction benefit, but just some generic. She happens to have custom. So I told her those are not the fix, because you didn't need them a year ago. And the hope will be that we can wean off of those and we actually don't need them when we manage the running dose a little bit better. So she is on the Clinical Athlete Retainer Program. So what that means is she's going to see me about once a month, and then I'm going to consult with her remotely on the day-to-day as she's going through her programming. I'm going to touch base with her coach. I'm going to get her program so I can have it in front of me, and we're going to break up the jogging distance before her symptoms set in. So right now she's coupling sprints, multiple bouts of sprints with like calisthenic movements, and then she's doing longer steady state on top of that, like either right afterwards or the next day. And so I'm going to have her break up the sprints and put them on their own, and then in the circuits that she's doing, I'm going to have her do like the Aerodyne or the rower or something else that's going to give her a cardio stimulus, but she can focus on the running as a standalone quality, so she's not already fatigued and maybe hitting hard with the foot, or if fatigue is a generator for her symptoms, she can be more fresh when she's running. And I'm going to recommend that she break up the longer runs So if it's a 2-mile run on the docket, but she knows she's going to feel her symptoms at the 1-mile mark, we may do bouts of 3/4 of a mile rest, 3/4 of a mile rest, 3/4 of a mile rest. That'll actually put her over 2 miles, but she'll be able to maintain a better pace and maybe stopping just short of when her symptoms arise. And then obviously over time, we'll hope to consolidate those intervals into longer runs that she'll be able to tolerate longer distances without her symptoms setting in. We'll throw in the heavy, slow resistance in the calves, really just, again, single leg calf raises to a deficit, just for direct loading of that tissue that's irritated, to try to get some load tolerance there. We'll do twice a week, 3 to 4 sets of 8 to 10 repetitions with a 3 up, 3 down tempo. And as I mentioned, I'm going to suggest to her coach that we go heavier with the single leg work. And if needed, we'll decrease frequency of the running and give her a little bit more time in between bouts to recover, and we can build energy systems with low impact implements. We'll gauge that the next couple weeks. So in regards to prognosis, you know, the police academy training, the fact that she is potentially going to be in it in 6 weeks, it's a 6-month long process, and I'm sure I've never done it, but I'm sure it could be rather grueling and demanding, and they don't necessarily care if your right foot hurts a little bit, but you do, because it's hurting your training and it's uncomfortable. So it's a significant confounding factor. This is not ideal, to be rehabbing a chronic injury at the same time that you also need to be peaking for a life-altering event that spans many, many months. So we had the conversation, you know, we may have to prioritize rehab and symptom reduction with performance. And I kind of had the recommendation, and she was on board with it, that maybe we're prioritizing performance, right, you know, initially, to try to give her the fitness level needed to start the academy. Obviously, though, with the goal of no more increase in symptoms. But if function can improve and fitness can improve and symptoms at least level off a little bit, that's still a small victory. And then hopefully over time, the symptoms can desensitize as well as we get a handle on her training. If you guys have any questions about these cases, I'm posting them and discussing many of them in the Clinical Athlete Forum, on my YouTube channel, on obviously Instagram TV. The Clinical Athlete Forum is where we talk about lots of different stuff in regards to sports med, rehab, and athlete performance. More information can be found on clinicalathlete.com. You can find your nearest clinical athlete provider also on clinicalathlete.com, and any continuing education events as well. Thanks, guys.